If you don't understand this one rule, your entire joint mobilization goes wrong. And this one rule decides whether your patient improves or gets worse after treatment. Today, we are mastering one of the most important concepts in physiotherapy, the concave convex rule. And trust me, if you truly understand this rule, your joint mobilization never goes wrong again. This is not just important for your exams like CET or physiotherapy university exams, but this is what actually decides your clinical accuracy. Also, if you are preparing for CET seriously, I'll tell you about my mentorship program in the end. Let's understand osteokinematics and arthrokinematics. Osteo means the bone, that is defined as movement of the bones in the space. Arthro means the joint surfaces. That is why arthrokinematics is defined as the movements occurring specifically at the articulating bone ends, also known as joints. The major difference between osteokinematics and arthrokinematics is that osteokinematic movements are volitional movements, that is, they can be performed actively by the patient. They are voluntary movements. Arthrokinematics are non volitional movements, that is, you cannot isolate them. They are always accompanied by the osteokinematic or the bony movement. Normal movements of the osteokinematics occur in the traditional cardinal planes and axes, which we define as flexion, extension, abduction, adduction, and rotation. Arthrokinematic movements consist of roll, glide, and spin. For example, if we flex the elbow, the movements of the radius and ulna end towards the humerus forms the osteokinematic movement, that is, movement of the bones. Whereas the movements that happen at the joint surface, that is articulation of humerus with radius and ulna, forms the arthrokinematic movement. If this arthrokinematic movement, that is the slide, glide or spin, whatever happens at the elbow joint is limited, the entire range of osteokinematic movement would be limited. If full accessory motion doesn't occur, physiological motion will be limited, that is range of motion would be limited. You cannot restore full range of motion without restoring the slide, and this forms the basis of your joint mobilization. Moving on to the core mechanisms of the arthrokinematic movements, which involve roll, glide, and spin. Now roll. Here, the new points on one surface come into contact with the new points on the opposing surface. For example, if a tire is rolling on the road, every point on the edge of the tire, that is every point on the circumference of the tire, will meet every new point on the road as it moves forward. For example, this diagram, this is a circular ring which moves on this flat surface. Now each moment of this ring, whenever it moves, will come into contact with the each point on this surface. Rolling is always in the same direction as the swinging bone, whether the surface is concave or convex. Just remember this for a while. We shall discuss this in detail soon. Now glide. A single point on the moving surface comes in contact with the new points on the opposing surface. This requires congruent surface. So here, now if this is your ring moving on this flat surface, this point of the contact of the surface with the ring will be the same whether the ring is on this side or it moves further ahead. Unlike roll, wherein new points of contact of the ring come in contact with the new points on the surface. Let's move on to spin. So spin is rotation of one bone segment, that is rotation of one bone segment around a stationary mechanical axis. The point of contact of rolling surface may change, but the point of contact on the stable component never changes. Let's understand the most important Cartan bone concave convex rule. Let's understand this. This is a convex surface and this which looks like a cave is concave surface. Now the moment of the bone is always defined by the distal end of the bone. When the convex surface is moving on the concave surface, the roll and the glide occur in the opposite direction. Whereas when concave surface moves on the convex surface, roll and glide occur in the same direction. This forms the basis of convex concave rule. So always remember, when the convex surface is moving on the concave surface, The glide occurs in the opposite direction. When concave surface moves on the convex surface, roll and glide occur in the same direction. Always remember this. This is the basis of your joint mobilization techniques. A basic joint has an ovoid architecture. It's made up of convex surfaces and concave surfaces. So convex surface, this is convex surface, the curved or rounded outward, the cartilage is thickest at the center and the surface. Whereas in concave surfaces, this is a hollow surface or rounded inward and cartilage is thickest at the periphery of the surface. Now, remember, joints are rarely in total congruence. So if joints are completely into congruence like this, there will only be slide, that is translatory motion, and this will increase the chance of dislocation. Therefore, human joints are rarely in total congruence. Accessory motions continuously alter total joint congruence to prevent dislocation during movement. Let's understand human joint anatomical physiological movements. So during human motion, rolling and sliding occur in different proportion. There is no pure rolling or pure sliding in any human joint movement. This happens to maintain joint integrity and prevent compression on one side and separation on other side. Look at this example. These are the two bony surfaces. The upper bony surface is moving away from the lower. That is, roll is happening. Now, example, if there is any capsule covering this joint surface, there will be no dislocation but separation on one end and compression on the other end. This compression will cause abnormal joint mechanics, which will cause microtrauma and pain and lead to joint dysfunction. If this surface is rolling on the concave surface and there is no slide happening, dislocation can happen. If there is a protection over it, this will roll, but there is compression occurring at this surface and separation occurring at the lower surface. This will cause joint dysfunction, microtrauma. Clinical correlation. Passive stretching using bone only causes joint damage. So this example rightly states, for example, there is stretching happening of the muscle covering this joint. There will be separation at one surface but compression at the other surface, which will again lead to joint dysfunction. Sliding component therefore is necessary in maintaining the joint play. The roll without slide does not replicate normal joint mechanics. That is why we call it as dysfunction. Let's understand this with an example. This movement of humerus into abduction is carried out by the muscles which cause abduction, for example, supraspinatus deltoid and other accessory muscles. Now, if this movement of abduction, for example, this is glenoid fossa and this is humerus head. If there is abduction occurring but there is no slide downwards, there will be dislocation or compression on the upper end. Now, if this abduction is accompanied by a slide downwards, then this will be a physiological abduction motion. This downward slide is provided by the rotator cuff muscle. In cases of patients having rotator cuff dysfunction, this inferior glide of the humerus head will be absent, which will cause compression leading to shoulder impingement. Always remember this. CET, three examples of spin occurring in the joint of body. Only three examples have been given in our textbooks. Always remember this for your CET. The shoulder joint with flexion or extension, hip joint with flexion or extension, and the radiohumeral joint with pronation and supination. As we discussed compression, it is the decrease in the joint space between the bony partners. Now, normal intermittent compressive loads help move the synovial fluid because compression relaxation causes movement of the synovial fluid throughout the joint cavity, and this helps in nourishment of the cartilage and maintains cartilage health. But abnormally high compressive loads may lead to continuous pressure between the articular surfaces, which causes necrosis and articular degeneration and deterioration in the joint surfaces. For example, this occurs in osteoarthritis. Compression actually occurs in human body during weight bearing condition and when muscles contract, and this actually is important for providing stability to the joint. It happens when we weight bear or in the spinal joints where compression happens to maintain stability. Please understand traction is not equal to distraction. Let's understand this. In this diagram, this is the glenoid fossa, which is one articulating surface, and this is the head of humerus, the other articulating surface. Now, the longitudinal pull along the joint, along the bone axis is called as traction. That is the longitudinal pull, whereas distraction is separation or pulling apart. So this is glenoid fossa and the arrow showing this way. That is, it is distracting, separating the head of humerus from the glenoid fossa. Now our concepts for osteokinematics, arthrokinematics and concave convex rules are clear. We can move on to the treatment part. Step 1 is identify the concave bone. Always remember treatment plane is determined by the concave articular surface. In this diagram, this is the concave articular surface and this is the convex articulating surface. Next step is draw the axis. Draw a line perpendicular from the axis of the rotation to middle of the concave surface. That is this x to this line, which I am pointing out from x to the middle of the concave surface, and this is a perpendicular line, is the axis of movement. Step 3 is apply the force vectors depending on the requirement. For example, if you want to apply distraction, this is always applied perpendicular to the treatment plane. So this was our treatment plane, which is always parallel to the concave surface. Distraction force will be perpendicular to this plane. That is where this arrow points out. Separation between the convex and concave surface is called as distraction. If you want to apply gliding, it is always applied parallel to the treatment plane. Here, this is the treatment plane. If this convex surface is moved up or down, it will be parallel to the concave surface. That indicates gliding. Now we understood joint mobilization, but what is the clinical relevance behind this? Let's understand the two techniques, that is Carlton bone and Maitland mobilization, which help us do these mobilizations. Now, why are these important? It helps us restore joint play, decrease pain, and help stretching capsular tissue using passive movement, graded force, and this helps us increase the range of movement. For example, if I ask you to do elbow flexion, the entire range of physiological anatomical limit of elbow flexion is 120 degrees. So the anatomical limit is the whole physiological range that should have been available. But due to some pathology or XYZ reasons, the entire range is limited to 110 degrees. That is, we lack by a 10-degree gap, that is, you feel tissue resistance at the end of 110 degrees. That is the available joint play in this case. So we will do mobilization to increase this from 110 to 120 degrees. How? We can choose either of the techniques, Carlton bone or Maitland, depending on the preference and requirement. Let's understand Carlton bone in detail. Now step 1, that is grade 1 in Carlton bone, is called as loosening. So if there is compression occurring at the joint surface, grade 1 is just separating these, that is bringing about the normal joint space that should have been available. Grade 2 is tightening or taking up the slack. For example, if a string is just lying down, just think of a string or a thread is just lying down. It would be in a haywire and a crampy pattern. If I just hold up that string and hold it in a straight line, I am not stretching it, I am just holding. I am just removing the crimp and the haywire pattern. This is called as taking up the slack. Okay, this is grade 2 mobilization. That is, from the starting point till the tissue resistance I feel, I will be pushing the joint movement. Now next 3, that is grade 3. This string I am going to stretch. So now I am giving the stretch. Until now I was just straightening the string. So now grade 3 involves stretching. That is, when you push the joint, you go beyond the tissue resistance which you feel and try to enter in the anatomical limit that should have been available. but yet you are not moving only in the anatomical limit. You begin with in the mobilization in the starting position, gradually progressing towards the tissue resistance, and post that you do stretching. Once this is achieved, you may just do mobilization in grade 4, that is between the tissue resistance and the anatomical limit. That is, you push the surface. Once you feel the tissue resistance, you push in further until the anatomical limit is reached. This is called as Carlton-Bone mobilization. Next is Maitland mobilization. So Maitland involves 4 grades of movement. Grade 1 includes small amplitude rapid oscillations at the beginning of the range. So again, in the starting position, we give small amplitude rapid oscillations in only the beginning of the range. So if this is one surface, this is the other surface, you are just giving small movements at the beginning of the surface. Okay. Grade 2 involves large amplitude oscillations within the range, not reaching the limit. So first you push until you find you are in the range, not in the beginning position. Now, and inside this available range, there you will do joint mobilization, that is small rapid oscillations. Now here, these oscillation doesn't mean you will do it from the starting position till the mid range. You will push till the mid range and just do large amplitude oscillations within the range. But yet here again, you will not reach to the limit. Progressing to grade 3, there will be large amplitude oscillations up to the limit of available motion. So you push onto the joint surface until you reach to the place of tissue resistance. Now here, when you reach to the tissue resistance, you give large amplitude oscillations up to the limit of available motion right now. This causes stretching into the tissue resistance. Next, we progress to grade 4, wherein we have crossed the tissue resistance and now we go beyond the limit of tissue resistance. That is, we give small amplitude oscillations at the limit of tissue resistance to finally achieve the anatomical limit. Let's apply the same concept to shoulder joint movement. So this is the anatomy, this is the glenoid fossa, this is the head of humerus. Convex humeral head moving on the concave glenoid fossa. The action of the movement we are seeing is abduction. Mechanics, that is convex, is moving on the concave. Come on, recollect, if convex is moving on the concave surface, roll and glide occur in the opposite direction. So the roll will occur superiorly and glide will occur inferiorly. The roll will be provided by the shoulder abductor muscles and the glide will be provided by the rotator cuff muscles. So glide, articular surface must slide inferiorly. Very important, we discussed this in the previous slide as well. Without concurrent inferior glide, so if there is no glide downwards, this moment of roll will cause compression here and separation here. So this compression is what we term as shoulder impingement, which continuously keeps on doing micro trauma, pain, and that causes abnormal dysfunction that is also called as shoulder and scapular dyskinesias. Carrying this concept to one more clinical application, that is knee joint movement of extension in an open chain. Consider sitting on a chair with your knee going straight up into extension. Here, the concave tibial plateau will move on the convex femoral condyle. Just recollect and let me know, when convex surface is stable and the concave surface is moving, the roll and glide occur in the same direction. Roll is defined by the distal end of the bone and glide by the proximal joint surface. So open chain sitting, the roll is happening in the superior or anterior direction and the glide occurs in the anterior direction or superior direction, that is same direction. So concave moving on convex, roll and glide occur in the same direction. Let's take a look at indications, contraindications and precautions while doing joint mobilization. So under indications we have pain, reflex muscle guarding and spasm at the painful joints. So here our joint mobilization techniques are going to address all of these via two mechanisms, that is neurophysiological and mechanical effects. Neurophysiological effects include When you do continuous oscillations or give a passive stretch, these oscillations cause vibratory, that is mechanical effect, the signals for which are carried by the large diameter fibers, and they inhibit the pain gating and the pain signal transmission, which helps reducing pain perception and thereby the pain. Mechanical effects include continuous compression, relaxation, followed by compression and relaxation at the joint surfaces. This causes synovial fluid movement, which nourishes the cartilage and thereby reduces the pain. It also helps reverse joint hypomobility, which can be due to progressive limitation of diseases that limit the joint movement, for example, rheumatoid arthritis, or functional immobility, for example, patient who is unable to do any movements, which leads to static positioning of the joint and causing hypomobility. So these two, that is reversing joint hypomobility, can be done by the oscillations or stretching within the tissue resistance or even up to the anatomical limit, thereby helping stretch the articulating surfaces, that is the contractile and the non-contractile surfaces surrounding the joints. Also positional faults, for example, we discussed in the shoulder impingement example. Because there is absence of inferior glide, the humerus keeps on compressing the acromial area and we get shoulder impingement. So these positional faults, moment with mobilization techniques attempt to realign them, and once the faulty tracking is corrected, there would not be continuous microtrauma and no dysfunction therefore. Let's move on to contraindications. So hypermobility or inflammation or joint effusion. All of these, in all of these, the joint capsule is already at a stretch. For example, in inflammation or joint effusion, the capsule is already stretched due to accumulation of fluid inside the cavity. Now, the joint movement is limited, but it is not due to limitation of the capsule or the mobility. It is because the capsule is stretched, there is extra fluid, and there is muscle spasm. So, the actual treatment for it would be reduction of the swelling. In case there is pain accompanied by each, we can do gentle oscillation or distraction motions, which will temporarily inhibit the pain response via mechanical and neurophysiological properties. Now, precautions which we should take in certain cases. For example, if there is malignancy, the joint and the bones would be fragile, so we have to be precautious to not cause any dislocation or fractures. Similarly, acute phase tissue healing, here the tissue is just healing and is very fragile. We cannot push or else we will cause disruption of the tissue. Bone diseases detected on radiograph, for example, osteomyelitis, infectious joint or systemic connective disease, example rheumatoid arthritis, where there is already hypermobility available and we don't want to dislocate the joint. Elderly and very frail individuals, again the bone quality is poor. To avoid hazardous effects, we have to be very precautious while giving joint mobilizations. Elderly individuals with weakened connective tissues and diminished circulation again fall into a criteria of precaution while doing joint mobilization. Now we have rightly understood the concave convex rule, but rule versus reality check is really important. So there are two studies that I have mentioned here. This is a good to know part. So Neumann et al. In 2012 stated that the rule is highly useful educational heuristic, that is concave convex rule is an absolute law and is very useful in educational purpose. However, it should not unequivocally dictate the direction of manual glide without physically assessing actual joint tension. So without actually assessing the joint, we cannot blindly apply the concave convex rule because every time every patient might have a different joint mechanics, a different surface kinematics, and so after assessment the glide which we have to apply, that is to be decided taking concave convex rule into consideration, but always remembering rule is not same as reality. There's one more paper by Scavell et al. In 2019. The reality is that when CT imaging of the deep knee flexion, that is kneeling, was done, it showed that femur actually translates posteriorly in opposition to what it should have done to posterior rim of tibial plateau. This is coupled by external rotation, challenging the simplistic linear models that we might consider otherwise. Knowledge check, let's quickly do about arthrokinematics. So now you have to answer based on the Carlton-Boone concave convex rule. When a convex joint surface moves on a concave surface, in which direction does the arthrokinematic glide occur? Answer yourself. You're right. It occurs in the opposite direction to the angular bone movement. Knowledge check 2. Now we have to move to clinical application. A patient presents with severe joint stiffness and limited range of motion, but minimal pain. According to standard mobilization grading, which technique is most appropriate to stretch the tissue resistance? You're right. The answer is grade 3 mobilization. So, it uses large amplitude rhythmic oscillations which are performed up to the limit of available motion to specifically stretch the tissue resistance. Because the patient has minimal pain, we can go up to the tissue resistance, and because the patient has severe joint stiffness and limited range of motion, again that indicates us to go towards severe tissue resistance stretch. So grade 1 and 2 are primarily for pain and fluid management, whereas grade 3 and 4 are to increase the range of motion and decrease joint hypomobility. Just remember this table for your CET, for your answers, for your Viva and your clinical accuracy. So cartilage architecture, concave on convex. The concave surface has thickest cartilage at the center and the glide is opposite to the bone swing. Clinical example, the glenohumeral abduction. The roll is in the superior direction and the glide is in the inferior direction supported by rotator cuff muscles. Next, moving on to concave surface, moving on to convex surface. The thickest part is at the periphery, that is rim of the joint surface, and the glide direction would be same as the bone swing. Example, tibiofemoral extension. The roll and the glide both occur in the anterior direction. Next is mobilization plane. It is always determined by the concave bone and distraction is perpendicular, glide is parallel. Always remember. अगर आप CET क्रैक करना चाहते हो with clear concepts and not just mugging, I'm starting a structured mentorship program where I personally guide you with your concepts and strategy. Details are in the description and pin comment. Let's just not study physiotherapy. Let's master it. Master your clinical reasoning. The concave convex rule is your foundation, but your hands and clinical assessments are your ultimate guide. Like this video if it helped you understand arthrokinematics. Subscribe for more clinical biomechanics masterclass. Comment below what joint you want me to cover next. Thank you.